to invite now Dr. Jay SHETH to talk about first-line treatment for PDR anti-VEGF therapy. Dr. SHETH.
So at the onset, thank you very much APAO and AIOS for this excellent opportunity to show evidence as to why anti-VEGF therapy is a better treatment option for patients who have PDR. So these are my financial disclosures, none related to the work that is being presented. So we know that PDR is one of the severe complications of patients who have diabetes, and it is primarily driven by an overproduction of the VEGF levels. And this VEGF surge leads to multiple complications, including vitreous hemorrhage, tractional retinal detachments, leading to severe amount of vision loss. Now, historically, all these eyes have been treated by a pan-retinal photocoagulation to manage PDRs. And what is the rationale? So rationale is basically to kill the retinal tissue, and which ultimately leads to a reduction in the metabolic demand of the retina and thereby reducing the VEGF levels. So however, this method does come at a very high price. So we are essentially sacrificing the peripheral normal retinal tissue also along with the diseased part. And to just put into perspective, it's actually like using a sledgehammer to just cut open a nut. So we need better options for this. So therein emerges the role of anti-VEGF therapy, which is a game-changing alternative for managing all these PDR patients. So these anti-VEGF agents, it actually targets the root cause of the entire disease process, that is a VEGF. And there are multiple treatment options which are FDA approved, are available for treatment of these conditions, and with an emerging amount of biosimilars, especially in the developing nations and also in the developed countries. So it not only halts the progression of the abnormal blood vessel growth, but also preserves the overall integrity of the retina. And there are multiple randomized clinical trials, especially the Protocol S, that has compared both these treatment modalities against one another. And it has shown that anti-VEGF therapy can help achieve non-inferior visual outcomes as compared to the PRP treatment. But the benefit actually doesn't stop here. The patients who were treated with anti-VEGF therapy have shown a lower incidence of visual-threatening DMEs, fewer cases of vitrectomy that were needed, and significantly less loss of peripheral vision. So overall, when we compare both the therapies, we are actually saving not only the central vision for the patient, but also the peripheral vision when we select anti-VEGF over PRP in all these eyes. Then there are other studies such as the recovery trial that actually compared aflibercept monotherapy that were given in a monthly dose as well as on a quarterly dose. And it has shown that over 2 years, the DRSS score improved in almost 82% eyes, and it was stabilized in 18%. Now here, one very important thing is that there were absence of any cases of worsening of the DRSS that were there. And even looking at the angiographic biomarkers, the treatment with aflibercept led to an improvement in the non-perfusion index, microaneurysmal count, any other parameters. So then another concern is the injection burden, where how many injections do we need to give. So if you look back at Protocol S, there were 7 injections needed in the first year, but from the second year onwards, only an average of 2.5 to 3 injections were needed for those patients. And even the recovery study has shown that quarterly injections are as good as monthly injections, and giving, although there might be a modest benefit with monthly injections. So if we look at the newer treatment regimes, such as the treat and extend, as well as the newer anti-VEGFs that are coming up with a longer durability and those implantable devices, it can definitely help us reduce the further burden of injections when we treat with anti-VEGF monotherapy. The next very important concern is, of course, the cost effect for all these patients. PRP is definitely much more economical when we compare to anti-VEGF therapies. So at first glance, although it may appear that way, but then if we look at Protocol S, almost 50% of the patients who were treated with PRP needed an additional laser session. So when we look at the cumulative cost, although the anti-VEGF may be marginally higher, but with the biosimilars and all coming up, it is definitely going to bring down the overall treatment cost. And what about the healthcare needs? So there was definitely more need for vitrectomies and other patient care that was needed in patients who are treated with PRP alone. So overall, the cumulative cost may increase, as well as we have to also look at the productivity of the patient itself, with multiple hospitalizations that are needed, with PRP causing vitreous hemorrhage, increased risk of TRDs. So all these also need to be taken into account. Then addressing the safety. So the endophthalmitis rate is very, very minimal when we look at the cumulative data. And also meta-analysis studies have shown that the systemic safety is also very good for all these agents. So this is a very interesting paper that was published by Prithvi Mrutyunjay and their group, where they actually compared the rate of laser treatment as well as the rate of anti-VEGF therapy after the publication of Protocol S. So if I look at the lower graph pointed by the red, so that is a PRP, and if you look, the rates of PRP are actually falling. Whereas when I compare with the anti-VEGF therapy, definitely after the publication of Protocol S, there is a greater increase in the rates of anti-VEGF monotherapy that are being advised by the US physicians themselves. And so this trend just reflects an increasing confidence with this therapy modality. And also there are other papers that have published that also confirm the higher rates of vitrectomy as well as vitreous hemorrhage and TRDs with PRP as compared to anti-VEGF therapy. So this was one of the interesting cases that we had actually published in AGA case reports, whereas the patients were treated with 3 loading doses of ranibizumab, and on this side we see that there is complete absence of neovascularization of the 3 loading dose, as well as we were able to demonstrate a reperfusion that is also happening in the areas of retina. So just to conclude, as we move towards an era of precision medicine, it is very clear that anti-VEGF therapy represents a major leap forward in the treatment of PDRIs. So this approach not only targets the underlying cause, that is the VEGF overexpression, but also preserves retinal structure and function, offering our patients a superior quality of life as compared to traditional PRP. Thank you very much for your patient listening.